Currently, we are in Addis Ababa for this workshop. This is the first in-present workshop that we have on this project. That involves 10 countries in Africa, aiming at testing some new developments of diagnosis and surveillance for various diseases that are useful for having a quick and reliable diagnostic of the viruses. So in the first phase of the project, we collected more than 1,500 samples in 4 different countries in Africa, plus Italy, on SARS-CoV-2 patients. And with those, we explored a new technology, which is called LAMP. It's an isothermal amplification, is a molecular technology. It's similar to the RT-PCR, which is the technology used for molecular detection of SARS-CoV-2. But the LAMP has certain advantages over RT-PCR. It's low cost, it's colorimetric, doesn't require specific equipment, and therefore is more amenable for diagnostic in difficult settings.
In our context, a community laboratory in Africa do not have a biosafety cabinet. The community laboratory in Africa cannot do a molecular testing because they don't even have a facility to do nucleic acid extraction.
The one equipment that is standard is the light microscope for detection of malaria cases. Other than that, you don't have any other equipment such as a PCR machine. They don't have a biosafety cabinet. So basically, it's just that light microscope that they have because they also do not have access to electricity.
Because we are very much underfunded for research. And so therefore we lack technologies, we lack reagents. Whatever in Europe you can do in 1 or 2 days, perhaps for us we can only do it in a month, 2 or 3 months. So this constitutes a huge challenge to all of us.
So we initiated, the first phase of the program was to really perform this technology in different countries and assess if it was efficient and sensitive enough for a clinical diagnosis of the virus.
Ethiopia is one of the 10 African countries involved in this project. We tested in 10 labs, 10 community labs, including my lab, and we found that the test was very powerful.
LAMP kits, to me, are best for the community because they're in the community. If they have the LAMP kits, as long as there's electricity, they can test it. They can use the LAMP kits to analyze the samples. Then anyone that is negative can now be shipped to the reference lab that has the sophisticated equipment.
Another thing is that it does not require professional training. Unlike PCR that requires a lot of training, this technique is very straightforward, particularly when it comes to the interpretation of the results. The results are interpreted in the sense of just a color change, which is easily detectable to anybody.
In our context, we must say in the herd pyramid, we have the central level, the intermediate level, and then the peripheral level. So within our health system pyramid, we know already that the majority of people go towards either the peripheral level or the intermediate level. And this is more than 50% of patients in our context. So bringing in LAMP is really going to contribute substantially for disease surveillance and also for clinical management.
The producers of LAMP kits should see how it can be used without need for biosafety. That's for the extraction. If that extraction something is removed, so that the LAMP kits can be operated, can be used without extraction, without the need of biosafety cabinet, and yet maintain the safety that we all require for both the personnel and the community. That would be a milestone for the LAMP kits.
Now we are on the way to get national regulatory approval. We have already applied. Most of the African countries already applied for registration and approval in their respective countries for utilization of this tool for detection of different viral diseases in addition to SARS-CoV-2.
This was a workshop that involves both the discussion of the data, but also a practical part. The practical part was to introduce this technology to the members of this network and to overcome, all the little details that only by doing something you learn. And we took advantage of the hospitality of our colleagues in Addis Ababa. So at the ABTI laboratory, we could repeat the testing of few samples together with the members of each laboratory, participate into the network, and to go step by step into the protocol, just to highlight what are the bottlenecks, what are the problems in the protocol.
We showed saliva testing by RT-LAMP. We showed also to our African brothers about detection of SARS-CoV-2 on nasopharyngeal samples. We have showed also real-time PCR testing, and in addition to that, we have showed also cell culture, cell culturing, virus inoculation, and all the activities were done in our lab, and most of the Africans were very happy, and they have given us a lot of feedback.
When we were asked to join phase 2, our major worry was, how are we going to start this in our country? Where do we learn from? Who is going to be like our mentor? But we are happy that the countries which participated in phase 1 were very willing and forthcoming to assist us to set up our system and to be mentors in terms of how to start up the testing technology for land, and also to give practical ideas and lessons learned from their phase 1 experience. And we were able then to have a springboard to stand on and move on with our own program. And we had very little challenges because of the assistance of the phase 1 countries.
One aspect of this meeting was to review the data from the clinical trials on SARS-CoV-2, which is still circulating in the countries and still a clinical problem. But we went a step further. We now want to expand this technology to other viruses.
And we're talking about dengue, talking about chikungunya, and even yellow fever.
These days, because of the climate change, the mosquitoes which were not in Ethiopia, now they spread from the lowland to the highland area. So the number of cases are increasing day by day. We are working with ICGEB on sequencing of these arboviruses, so that we will devise method of prevention or method of treatments, maybe vaccination as well. So in the long run, we will have some strategy to control this disease.
If we find the right primers, we actually can design them for any other virus. So we just need to work on it. This is a big step as well, because we're coming from one place, and then we realized that this worked, and then we want to move on. And number one, move on to other viruses. Number two, adjust that with the sequencing as well. It's not just thinking in an individual way, it's more thinking in a regional or continental way and applying all this to your own country. So at the end of the day, what you're doing is empowering our institutions to do better.
You cannot restrict a virus to a country. The virus don't know any borders. They just tend to circulate in the population, and therefore it's important really to enable locally to be able to contain an infection globally.
We can't fight against this emerging pathogen alone. We have to be together. We need North experience from North, we need experience from South, so we have to collaborate North-South, South-North, and everywhere we can create a very hard network to standardize the method and to share experiences on disease fighting.
And all of these cannot be done only through the collaborative project or valuing collaboration partnership with research institute, but also with diagnostic company and the community. That's why I really appreciate, as I said, really appreciate this network, which maybe also contribute to go beyond the project scope.
We need to get our strength together. We need to empower ourselves, and we need all of us to have a common goal, common language. And at the end of the day, if we have one disease like a COVID, it's not just Italy or Angola or just Africa, it's global.